The trajectory of your career just seems incredible.
Thanks. It's great to flatter your guests before they speak. So your job was perfect on that. So.
At the top of my notes, that's what it says. It says add compliment, right? First thing, yeah. No.
Yeah, Devin, we've had other guests that we kind of criticized before it started, and it didn't go well. So we flipped the script on this one.
Devin Gross is a pioneer in the digital patient engagement space, beginning at Emmi Solutions in 2003 and serving as a CEO for almost a decade before it was acquired by Wolters Kluwer in 2016. Following his 14-year stint at Emmi, Devin went on to helm SonarMD, a technology providing care management for complex chronic conditions that use high-cost drugs, where he applied his knowledge of enhanced patient engagement, care coordination, and specialty pharmacy optimization to improve the experience for both patients and clinical teams. Devin holds a BA in International Business from Lehigh University, an MBA with a concentration in Healthcare Administration from Temple University, and has completed a fellowship in hospital administration at the University of North Carolina Hospitals. Devin is currently the head of portfolio management at Primus, where he oversees internal and third-party operating resources and works with companies across the portfolio to identify and implement operational best practices. Devin, welcome to the show.
Thanks for having me. Great to be here.
Thanks so much, Devin. Actually, I'm going to go off script just to start, if that's okay, because it just kind of came to mind. So Devin, we've been a big fan of yourself and the Emmi story since we started. I would say probably very early on with SeamlessMD, as we got into patient engagement. We'd hear about Emmi probably everywhere, right, Alan? Emmi would come up often and often. And so the opportunity to get to know you and learn your story, and given the fact that you and your team paved the way for patient engagement, is just, we're very grateful for how you've helped build the category over time. And I think one thing that I've learned being in healthcare for many years now is that you've got to be a little bit wonky to want to build a company in healthcare because of, all the barriers, the red tape, the long sales cycles. So I was wondering, what made you so driven to kind of keep doing this? I'm sure you ran into this to like a bunch of roadblocks. Like, why is healthcare something that you just keep coming back to?
It's a good question, and throughout my career I've asked myself the same question, to be honest with you. I got into healthcare, graduating from college, really struggled with what I wanted to do, and always liked business, but wanted to do things that I thought were you could really help people with. And when lots of my friends were going into financial services, I was kind of the oddball that was going into hospital administration, which at the time no one kind of even knew what it was, and I loved it and I was passionate about it. And after hospital administration, I'd sit in rooms and we talk about budgets and we talk about physicians, we talk about nurses, all incredibly important things. And no one ever really talked about the patient at the time. And, when I got into Emmi and we started this dialogue about the patient and began those conversations, and it was enlightening for me. I think it was enlightening for the market of what do you do and how do we change that? And that opportunity just became super exciting to continue to pursue.
And actually, Devin, starting there, so when you first joined Emmi, it was in 2003. I think back then iPhones weren't even a thing. Cloud computing wasn't a thing. Was technology-enabled patient engagement even a thing back then, or was this landscape completely barren and you were kind of the first to enter it and first to basically set the stage for patient engagement?
Great question. So let's just set the technology framework. Around 2003, the ability to stream kind of multimedia imagery or content was just becoming a thing. And it was nowhere like it was today. And one of our things that enabled us to do what we do is the ability to pace the way content was coming over the network to allow for a user experience without everything locking up. So that was early on, and that was a unique differentiation. The patient engagement, we did not come to market as a patient engagement solution. So to answer your question, nobody cared and nobody talked about it. So we came to market as a risk management solution, and our premise being the founder, and I was not the founder of Emmi, but the founder was a gentleman by the name of David Sobel, who was a lawyer who went back to medical school. And early in his residency was asked to consent patients for surgery and realized it was a crummy process. And he became passionate about that. And his wife, Michelle, was a film editor and was really good at telling a story. And the initial the initial premise of Emmi was, how do you better support the consent process? How do you deliver information in a way that people understand, comprehend, and actually document the informed piece of the consent process? And that led to two things. One, which was really differentiating for us, was the tracking of who saw our experiences and document tracking them at the individual level. But then preparing people for surgery. It wasn't until maybe 2006, 2007, when the government put out the first HCAP guidelines, where patient engagement actually became a conversation.
And Devin, I'm curious, how quickly did you end up making that, maybe not a switch, but that evolution to focusing maybe more on the patient experience beyond the consent process? I mean, immediately when that came out in 2006, was it a light bulb moment? Was it, I mean, I feel like when we look back in time, it seems obvious, but it probably isn't obvious in the moment that something was changing. So how quickly did you end up growing beyond the consent piece?
So we never ever gave up the consent piece. That was always part of the story. And everybody knows, and you guys are experiencing it, selling in healthcare is complicated and difficult, and you need to appeal to lots of constituents. So we never left that. And even though the government started talking about HCAPs in 2006, 2007, penalties didn't begin, and I don't remember the exact date, but penalties probably didn't begin until 2010, 2011. So even though there was a dialogue, there was not financial penalty to do so. So we had to continue to look for opportunities, and we talked about it, but we would look at and we'll talk about this throughout the podcast, I think, but really, how could we impact organizations in many buckets and tell a bigger story? Now, patient engagement became, a big umbrella for vendors and for the market and for the country. And obviously I think we were influential in creating the space, but we never put all of our eggs in that basket.
Gotcha. What was the initial reaction like to Emmi? Because I'm even thinking back, if we're talking about even 2003, even up to 2006, I'm not quite sure what access to broadband internet was back then, but even today, I mean, Alan, we might come across healthcare providers who even say in 2020, well, I have some older patients who may not have access to the internet. It's probably much even worse back then, 2003, 2006. What was the reaction like? Were people open to this back then, or what were the barriers to getting adoption?
Look, there was skepticism. I'm sure you have I'm sure much of the skepticism that we saw then, you probably still have, that seniors aren't going to use digital technology, and this is only a subset of the population, or are people really going to use this? So we absolutely heard that, and then it just became, how do you prove it? So the fact that we could track everything, we could tell you, and I used to walk into meetings and say early on, this is how it's going to play. If you give me 10 doctors, right? 4 are going to use it really well, 3 are going to use it okay, and 3 aren't going to use it at all. And from a patient standpoint, if we ask them to do this, roughly 65% of them are going to use it. And if we ask for feedback afterwards, roughly 20 to 25% are going to give us feedback. And that feedback from 25% was so phenomenal that even if, nothing else happened, we would put that data in front of the sponsors of the physicians and say, what else are you doing that you're getting this kind of direct feedback real time from your patient population? And that changed the dynamic and, would let us incrementally grow and expand. And some of our best, and I'll tell two very interesting stories here. One of our first big clients was University of Pittsburgh Medical Center, and that started with the risk management group. And Rick Kidwell, who, if you guys don't know him, runs the risk group, or the captive at UPMC, and I'm indebted to him forever, was just a great champion and advisor. And Rick always liked us, but Rick wouldn't go all in us till he sent a sample to his mom, who was having, I don't remember the surgery, and his mom came back and said, this is great and helpful. So that kind of said, okay, this will work for that population. The other is the physicians were very skeptical of us at UPMC, and the leader of the physician group, medical group, own group, who was always skeptical of us, needed a procedure and got an Emmi. And it completely changed his experience when he came back after that Emmi. And I can tell that story many times when people were skeptical, but then they or their loved ones or a friend experienced it and came back. I'll tell one more story if that's okay. Very, very, very early on, a general surgeon at Northwestern was using and said, hey, this is great for my gastric bypass patients, but for my lap choles or my hernias, I don't need it. And then he came back and said, you know what, lap chole and hernia is routine for me, but it's just as scary for a patient the first time as a major procedure.
That's right.
And it's not just for this, it's just not for, you know, a subset. Everybody needs this because it's new to everybody. It's not routine for the patient or the consumer, although it's routine for me. So those experiences over time began to change the dialogue.
It reminds me your story, the first one you shared about, you know, I think it was Ricky mentioned, once he shared it with was it a patient or a family member? And then they saw it for themselves. They go, wow, like this is the experience that I really needed. We actually had a health system. There's now a customer a couple of years ago where they were going through this competitive evaluation, and then the medical director, who was the clinical lead on the evaluation, took one of our demo counts home and you know, gave it to her mother. And she told us, you know, one of the main reasons why we picked SeamlessMD was the fact that this was the only one that my mom said, I can actually use this.
Yeah, so there you go.
But you can imagine when you're presenting to clinicians, they're all smart, talented people. They're more tech savvy than a lot of their patients. So everything looks like it would work for a patient. But when you actually put it in front of a real patient, you know, you might get mixed feedback there. So that makes a lot of sense. I was wondering, again, sorry to go off script so much, but you know, in 2020, you know, COVID, as awful as it was for the world, it really was has been a driver for more adoption of digital health in general and digital patient engagement. I was wondering, over the years, was there anything in particular that was a major turning point as a driver in the market for Emmi? Like, was it the penalties? Was it the H caps change? Could you point to something, or?
I think there were several things. I think, and I think we were good at following trends. When we started, risk management and med-mal. You could not pick up a newspaper in this country without reading about the med-mal crisis. So our ability to get in that was helpful. I think HCAPS was helpful in the market. I think readmission policies were important. So, you know, we focused messaging on that. As value-based care came out, we focused messaging on that. I'll tell you what I think was really bad for us, which at the time everyone thought was going to be good, was the meaningful use guidelines. And I think the meaningful use guidelines actually set back innovation for a couple of years because they set the bar very low, and organizations were very focused on checking the box and getting their financial incentive, but they wanted to do the bare minimum, which the bare minimum, you know, was truly checking a box. It was not driving the market forward. It was not driving true patient engagement. And that was a challenge for us. And you know, around when that happened, you know, if you go back, that was around 2008, 2009. That was also the financial crisis. So you had, you know, financial crisis, you had meaningful use, you had the release of the iPhone. All three, any one of those three things could have crushed us. Mm-hmm. So finding what was important that resonated in the market to keep us going was important.
Makes sense. Alan, I think you had some other questions that.
Yeah, actually. So, Devin, I know a big part of your job at Emmi was to educate the market. And it's funny, you know, you've answered some of these questions already in story. And I know that you're a big proponent of using story to communicate different points. So I'm curious, how could you share your thought process on constructing the narrative that you used for Emmi to educate the market?
Yeah. So today, and I think I stumbled into this at the time, and I think, you know, years later, I coach a lot of people and talk about this. So I absolutely believe that people only buy things if you can clearly articulate how you're going to help make money, save money, or meet a regulatory requirement. And there's a lot of solutions in healthcare that sound really good and are doing the right thing. However, people aren't going to buy them because, you know, there's just limited resources to allocate in the market. So patient engagement unto itself is not a solution by itself, right? Patient engagement is an enabler to fix another problem. If my patients are more engaged, they're going to show up more prepared, and I'm going to cancel less procedures, which is going to lead to revenue. If I engage patients more effectively, they're going to be more satisfied, and they're going to give me higher scores on my HCAPS. if I engage someone appropriately, they're going to weigh themselves, and I'm going to on a more regular basis, and I'm going to change behavior, which is going to lead, hopefully lead to early identification of deterioration for something. So our conversations very much always tied back to, if you do this, what problem am I going to solve for what that person around the table cared about? Because at the time, no one cared about patient engagement, right? And there wasn't a patient engagement person. Now you began to get people that had maybe patient experience or patient engagement, and you would think that would be great for us, but they were focused on valet parking. They were focused on greeters. They were focused on things that didn't lead to clinical or financial outcomes.
Right.
So how do you tie those together in something that actually means something and is relevant to running the business? And I don't care what the business is, but I think that's the important part of telling the story.
It's a great point, Devin. And I think one of the sad things I've seen in digital health over the years is that there's unfortunately a very big graveyard of companies in the space. And it's not because of bad intentions. There's so many people trying to build important companies in healthcare with the focus of, improving the patient outcome or the patient experience. But to your point, if there's no alignment with a core business priority of a hospital, health system, or practice, it's not going to get adopted, right? To your point, there's too many competing priorities for them. And so I think one of the struggles that we've seen with companies in our space is that tension between trying to do what's going to help a patient with what's actually going to matter to the buyer in a healthcare organization. And sometimes they don't match, right? And I was curious, did you ever run into that in Emmi where maybe your team is saying, hey, Devin, we got to evolve the product in this way. We got to add these features that will help a patient. But then your customer, the health system, is saying, well, Devin, I don't really care about that because it doesn't help me make money, lose money, or meet a regulatory requirement. And how did you kind of balance those different of those values, I guess, internally?
Yeah, no, it's hard. And I'll tell a good story as it relates to that. At one point, we were redoing our mission, and we made it a company-wide effort to redo our mission. And, there was debates, the wrong word, but there were many conversations of our mission. The people in the company wanted the mission to be all about the patient. And that's right, and that's important. But if we did that and we only focus on that, we'd be out of business because the patient wasn't paying us. And the mission had to be, we were engaging patients to support payers and providers, right? And I don't know what the right semantics were, the right words were, but that connection of, if we do this, we're going to make this other group more successful, but it's this other group that's paying us. And you can't lose sight of that. And again, I advise a lot of businesses now, early stage, and I think that's the biggest challenge. And it's, unfortunately to say, doing the right thing is not going to, and you referenced this, Judge, there's a lot of people that have the best of intentions, but their businesses aren't going to succeed because they haven't made that connection.
Yeah, it kind of reminds me how I think internally, the way I think about it is our health systems to us are either they're our customers, but really they're our channel to the patient. And so the best way that we can make an impact is to have more health systems who have chosen us as their partner, so that way we can reach the patient. So, even if we can only accomplish maybe 80% of what we think should be in the product, I'd still rather have patients get the benefit of that 80% than none of them getting access to 100% of the product. You know what I mean? So, so definitely like what you shared about reframing the mission, definitely resonates. I guess one thing I want to ask you, Devin, is that, in a past conversation you and I have had, we talked about how I think some health tech companies have come out in the last several years that are trying to go direct to patient as a consumer and almost remove the provider from the equation. And I think from our past convo, you felt pretty strongly that providers are really important as part of the equation for getting patients a better outcome. And you kind of don't want them disintermediated. You don't think that's the right thing to do in many cases. Could you tell me a bit more about kind of your perspective on that and why you think providers are so key to improving that patient outcome?
Yep. So let me preface with, I have very strong views on this, but others that don't agree with me have built extremely successful businesses. So I'm not saying that I'm right in my perspective. But I do look. I've been in healthcare for a long time. I've worked in all sides of healthcare. I think at the end of the day, the patient-provider relationship is the most important long term, and I think it's been frayed by financial incentives in the system. I think it's been frayed by the hierarchy of payers and health systems influence on the providers. And I think as a result of that, you've had some frustration around access or relationship between patient and provider. But having said that, I think like healthcare, and Josh, as a clinician, you can attest to this. Healthcare is complicated. It's as much art as it is science. Longitudinal relationships of understanding what happens, and that bond that's built to determine how do I manage through things, what's the right thing to do. I continue to believe, episodic events digitally are nice supporting factors, but they're not replacement. Now, there are some things that it may be phenomenal at. So, if I have an urgent care issue with the kid with an earache, and I don't want to drive to the doc of the ED or the urgent care center in the middle of the night, is that a great resource? Is, behavioral health a great resource? Yes, but I continue to remain skeptical that at the pace and volume that they think the market's going to move, it's going to move at that pace, and that it's ultimately what the consumer wants, and that there's not going to be an unintended consequences as a result of that. I think, time will tell and the market will tell.
Mm-hmm. Gotcha. And Devin, just so maybe so that we better understand your perspective, or are you saying more about longitudinal care where providers really matter, but if it's more, let's call it acute care, then maybe it's fine, or
I think if there's episodic, non-emergent, then I think it's a nice convenience, and works out okay. But and if I'm chronic and I'm not deteriorating, or I'm not in a state of deterioration, and it's good just to get a touch in, and does it make it good? Yeah, then I think it's good. Do I think it's the only solution? No. And do I think, if you disintermediate that provider relationship when they need it and it's not there, is a problem?
Yeah, it kind of reminds me how, and again, maybe I'm giving an example of a more complex situation, but I had a family member who had a major surgery, and when she got basically she got readmitted, it turned out better that she went back to the hospital that did her surgery. She traveled a bit further to do that, but she had continuity with the original surgical team that cared for her, that had her medical record, because of course things weren't interoperable between hospitals anyways. And so I can only imagine how, if it's a complex situation, being bounced from provider to provider, missing contacts, it's going to be bad for the patient. Non-urgent thing that you mentioned, okay, probably okay. But I think what's interesting is that we're seeing right now, to your point, two different things happening, even just let's call it in telemedicine or video visit. So on the one hand, you have some health systems or organizations where they're white labeling their own telemedicine solutions. You have others that are using kind of this direct to consumer marketplace version. Both are existing. Some companies doing well in both. I'm curious to see how that shakes up. But definitely and certainly COVID accelerated that competition. So I'm curious to see how that shakes out, and if there's room for both of those. I think Alan, you had some more topics you want to dive into around maybe the patient side of Emmi, or
I did. Yeah, thanks, Josh. So actually, before getting into the nitty gritty of the patient side through Emmi, actually, Devin, in a previous podcast, you were sharing how the patient persona is temporary. It's a snapshot in time, yet so often the healthcare system views patients as patients, and we view physicians as kind of the experts that we would go to. And you went on to share, if we're going to move from this episodic care to more value-based care, we need to treat people and specifically our patients differently than the healthcare system has over time. So I'm curious, how did you navigate the challenge of providing a higher quality patient experience with these slower moving financial incentives?
That's a great question, and it's something we were very conscious of. And Josh mentioned the graveyard of vendors earlier. There are a lot of vendors that came out with solutions built just around value-based care. And, you know, as much sense as value-based care makes, and as much as it, you know, I believe will ultimately change the incentives and change behavior, it didn't move as fast as everybody thought it was going to. So health systems and physician groups began to invest in value-based care, but they were keeping the lights on in their traditional model. And, you know, we very intentionally told both sides of the story. So I don't care where you were. If you were years away from value-based care, we had a solution for you. If you were on the front end of value-based care, we had a solution for you. If you were transitioning between the two and you need a foot in both camps, we had a solution for you. And you just had to grow. Because I think, you know, what was that, 8 years ago, 9 years ago, you know, we sit here today and arguably we're in the same boat. You know, some markets have moved very quickly and some markets are not moving that fast, and people are still keeping the lights on in some form of, you know, fee for service, discounted fee for service, whatever you want to talk, but the incentives have not fully moved. And we get back to what's the right thing to do. And the right thing to do clinically may be the wrong thing to do financially when I'm trying to keep the lights on. And you gotta balance that.
Right. And so does that actually just go back to how you're articulating the product? Like it's the same product for both use cases, presumably, but it's how you're conveying that story.
Yeah, but we, you know, part of our model is we would try not to sell based on use case, right? So what our goal was to sell a enterprise license, and our enterprise license could be deployed in many different ways to solve whatever your business issue is. So if you're using us enterprise-wide and you have, if you went into IDNs, and I don't know, I haven't had these conversations in a while and it may have changed, but you would go to an integrated delivery network that historically had their own payer. So you'd have a payer that would be an Emmi client, you'd have a health system that was an Emmi client, and then they started their ACO. Now, the capabilities in the payer and the ACO should have been the same, and they rebuilt those capabilities. So, you know, we'd have to go resell there, but we didn't care. Whoever you were on that umbrella, you could use this and we can deploy whatever was to solve your problem.
Right.
As opposed to ACO buy this use case for us. It was up to us to go convince people we could solve their problems under the enterprise umbrella.
Yeah, that makes sense. And actually, just to get a little bit more granular into the product itself, in the past, you've talked about Emmi providing a medically relevant friend-to-friend conversation. Could you touch on the importance of language and maybe specifically tone in the language that you were using it and why that's important to change behavior?
Yep. So let me just, you know, people way smarter than I am came up with all these ideas. So I'm going to parrot other people's work and not take credit for it here, but I'm going to talk about kind of how we thought about this. So, you know, prior to Emmi, the vast majority of material out there was written by doctors for patients, right? And if I'm a clinician, what I would talk about is, here's where my incision is going to be, here's how many stitches I'm going to be, here's what follow-up is going to be. And the reality is that's not what people cared about, right? People cared about, when can I play golf again? When can I pick up my grandchild again? I'll tell a story that we used to tell all the time, and I may have said it in another podcast that you've heard about. But early on, when we started, one of our initial programs was LASIK surgery, and patients could ask questions. What do you think the number one question that a LASIK patient would ask?
When can I watch TV again?
Yeah.
When can I wear makeup again? Eye makeup again.
Oh, really?
Right? Huh. If you would ask the doctors, how often do you get this question? They would say not a lot. When you would ask the front office people who got the phone calls, how often you get it? They say all the time. So there was this breakdown in understanding of what people really wanted to hear. So that was one thing. So how do you make it relevant and talk about what you want to hear? The second is, how do you do it in a, there's a big difference between health literacy and general literacy levels. And, you know, everything we did was targeted at 6th grade health literacy level, because it's kind of new and it's different. People have different ways of learning. People like voice, image, and text. We reinforce all of those learning modalities in what we did. The voice of Emmi is a very soothing female voice, and that is intentional, because If you survey people who had a healthcare experience and ask what was the best moment of your healthcare experience, like I'm going to say 9 out of 10. I don't know if that's a scientific number, but let's just say 9 out of 10 said at some point there was a nurse who was typically female who's the one that put me at ease during the experience. And how did we extend that feeling from that patient-nurse relationship, an extension of what's being done? So those are all things that went in to the experience, which I think really changed the experience at the time, because prior to that, the focus was on printing up paper material, giving to you, having no idea if you ever read it, with no cultural sensitivity, with very little focus on, it was more about volume. So did I have a piece of paper for someone who presented in the ED with fistula, as opposed to I had an experience that someone who presented in the ED with fistula actually knew what to do that changed outcomes and behavior.
Right.
Can I ask you a bit more about, let's say 2020 now, when it comes to digital, patient engagement? So, more and more lately, we hear health systems, framing patients as consumers, and the need for systems to go digital and meet rising consumer demands with digital experiences. So, we hear a lot from health systems how they want to do more than digital engagement monitoring. They want to have a digital front door and acquire patients, digitally into their markets. And the fact that they want to use technology to start engaging patients across geographies now, so that a system in New York can get patients in California at some point. Do you believe, so it's making it easier, frankly, for them to compete, for patient market share. Ultimately, do you think, that these digital front doors and more technologies are going to result in better care, better outcomes, maybe better access for patients? Or are there any unintended consequences that you think health systems, should be thinking about?
I think this kind of ties to a question that Alan asked earlier, and I think going back to the persona, by definition, I think a patient is when they're getting care. Okay, by definition. I think if you look at healthcare broadly, it's about the person and the individual across a continuum of time between birth and death and all of the family that goes there. And there's many events that occur in between that, as opposed to that moment of when I'm the patient and when I'm not the patient. And, we got back to value-based care, and I think that begins to change that incentive. So when I was a hospital administrator, I worked at University of North Carolina hospitals. We had, I forget how many inpatient beds, but let's say we saw 35,000 inpatients a year. We did 400,000 ambulatory visits a year, and we served a catchment area of 1 million people. Okay. The catchment area of 1 million people are people that are people, not patients at the time. And that, in my opinion, it's how do you facilitate this ongoing conversation between patient to consumer to just person, where they are in the continuum. So to answer your question, Josh, do I think that can be done better with digital solutions? At 100%. But I think from a biased perspective of where I've sat in the industry, I think there should probably be more thought to, if it's done solely as a patient acquisition strategy, we're missing a massive opportunity, right? If it's being done solely as I'm trying to prevent a readmission from a reimbursement standpoint, we're missing a massive opportunity. And if it's thought of holistically and what is it going to do, then I think there's a lot of opportunities. I think if it's thought of in isolation, I think, to your point, I think there's going to be unintended consequences, and I think there's going to be friction in the system. So, a fragmented answer, and I hope it made sense, but the way that I think about it.
Yeah, so I think it underscores the complexity of the question and the landscape as well. And actually, I'm actually curious about maybe a related question. So, when I think about, let's call it clinician discovery or patients deciding where they're going to get care, I mean, there's brands, and some brands are growing, some are declining. By brand, let's call it health system brands. And then, of course, you can certainly look for a clinician, look at ratings, look at referrals and all that. Do you think long-term both are going to be still critical factors? Do you think long-term patients are going to choose based more on brand, or do you think maybe the fact that there's more transparency online, there's more social media, there's more data and outcomes online for clinicians now, they're going to pick more on clinician? Any thoughts on where you think that might be heading in terms of patient choice?
Yeah, I can give lots of answers on this, but I think I go back to the patient-doctor relationship. I still think the patient-doctor relationship is driving where a lot of people are going, and that's what's driven a lot of acquisition and consolidation in the market. I think big brands for certain specialties and certain centers of excellence make sense, and you'll continue to see that. I've been saying what I'm going to say next for a decade, and it hasn't happened yet, but I really believe it will eventually. But as you see the forming of greater health systems with greater breadth and coverage, their ability to go directly to the employer and contract with that employer with more favorable financial incentives to drive steerage into those networks, I think we will see. I increasingly, and I've said this for a decade, I think increasingly the value of the payer beyond administrative services is declining. And increasingly, as the provider systems broadly can provide tailored solutions for broad groups of people, whether it be relationships with managed Medicare plans or relationships with employers, you're going to see steerage change. And I think, Josh, to answer your question directly, I think people are going to be willing to make sacrifices for financial benefit and for relationship, right? I think for benefit design, for copay design, for access, because I'm tied, is ultimately going to change how people make decisions. But this has been a long time coming, but you can see the changes in the system, but it's a monolithic system that needs to change. And it's happening slowly, but it is happening.
Devin, you should come up to Canada sometime once COVID protocols go away, and then I don't know if you spend time here in the healthcare system, but see how different it is here. Good luck getting choice of where you get care here. It's fascinating, but we are learning here. So value-based care has been slower here, for example, but we just started doing bundles here. I think as of 5 years ago. We finally started testing bundles, and now in Ontario here, total joint bundles are mandated across the province now. So things are moving, but still, you can't. I don't think you can self-refer to a specialist. You still got to go through primary care. And yeah. I'm curious to see how it shakes up here in Canada as well, since it is quite different.
Yep.
Alan, any other questions, I guess, that you wanted to get Devin's thoughts on?
Yeah, that's great. So, Devin, I know you've answered this question probably thousands of times, but I think it is still a confusing talking point in the marketplace. So I'm wondering if you could very briefly describe how you think about patient education versus patient engagement, and maybe how those two terms kind of dovetail together.
Yep. So I think we want to engage people because we want them to do something. We want them to take a more active role in their care, right? And that could be, I want you to make an appointment. I want you to sign up for the portal. I want you to weigh yourself. I want you to self-care. I want you to do whatever. So engagement is tied to an action. Okay, now to get engagement, there are many things I can do. I may remind you. I may give you shared decision-making material so you're empowered to make a decision. I may educate you. So again, I'm empowered with information to take an action and do something. So in my vernacular, education is a subset of engagement, but we're not doing engagement for the sake of engagement. We're doing engagement to drive a behavior change or an action. And there are many tools in our tool belt that allow us to do that. And there's many modalities, taking this conversation full circle, 2003, there weren't that many modalities, right? There weren't that many safe modalities to do so. We now have multiple modalities to drive the action, education being one of them.
And then actually just maybe expanding on that, where do you think patient engagement can go, say, in the next 5 years? What's your view on how we can engage? Maybe modalities will change. What are your thoughts on the future of patient engagement?
Yeah, so something I've talked about a lot over the years. I still don't think the market's there. I think there's great opportunity for the market to get there, but I think two things. Increasingly, this concept of personalized and dynamic engagement. So everybody's different, and what I need at any moment in time is unique to me. And, you know, for the vast majority of solutions out there, you know, it may be one size fits all, or it may be three versions of it fit all. And increasingly, I don't think that's going to be sufficient. So that's one big piece. The second piece is the sophistication of data analytics continues to get better. And, you know, I've been a proponent, and, you know, I still don't think is happening. The data vendors are getting more sophisticated, and they're saying they're doing engagement, right? The data vendors do 17 things, and engagement is one of 17. It's probably the one they spend the least amount of time on.
Right.
So how do you take who does things great and who does things well and begin to tie them together, right? Mm-hmm. You know, the other thing, if we really move to value-based care, the concept, you know, EMRs were built to get bills out, right? And they are really good at collecting, what have I done? How do I code it? And how do I get a bill, and to manage collections, right? And order entry makes that process easier, and others. If we really move to value-based care, my need to get a bill out is much different. And these systems should move to more CRMs or PRMs, right? Patient relationship management. And if I'm in patient relationship management, then engagement becomes a big part of that. So how do I put all this together? How do I put the clinical input? How do I put my data analytics? And how do I put engagement to manage a longitudinal conversation across personas, if I'm a consumer, if I'm a person, or if I'm a patient? And like, I don't think there's a good solution there. I don't think anyone's telling a great story there. And I think there's a great opportunity in the market for it, in my humble opinion.
Amazing. Well, I think Dev, that's a great way to wrap up the maybe the patient engagement side of the conversation. Alan, if it's okay with you, maybe we go to the Fast Five.
Yeah, let's do it. Devin, thanks. It was a fantastic discussion. I learned a lot there. So the Fast Five, or what we call the lightning round, is basically 5 questions where we ask you, and you can answer them as quickly as you'd like, but it's just an effort to get to know you a bit better for our audience. So first question that we have, Devin, is what is your favorite book or book you've gifted the most?
Yeah, so if I'm going to take this from the book I've gifted the most. So I've got 3 kids. My favorite book that I read them when they were kids was a book called The Hippos Go Berserk by Sandra Boyden. And it's this funny kids book that I love. And, you know, anybody that we know, we give a whole series of Sandra Boyden books as the baby gift, and Hippo Goes Berserk is my favorite one in that. So probably not an answer you typically get, but that's the book I've gifted the most in my days.
Well, awesome. You know, Devin, we should do a round 2 where you can read us the Hippos Go Berserk.
I really love the Hippos Go Berserk. It brings a smile to my face every time. So
awesome.
Excellent. Awesome. So question 2, what is your favorite movie or TV series?
Look, I think it probably changes. The one that I've been referencing the most as my favorite is The Watchmen, that was on HBO recently. Yeah. Was one of my COVID watches, and I think it was an absolutely fantastic piece of work, and kind of the relevance in society today were just great on so many fronts. So that's my current favorite.
Have you seen the movie The Watchmen?
I've seen the movie, and I'm in the middle of the graphic novel right now. I'm listening to the podcast, so all in on that one. They got going.
Very cool. Very cool. Question 3: what is something in healthcare you believe that others might find insane?
Yeah, I could probably go on all day with this. I think the fact the system makes more money when you're sick than when you're well is probably a surprise. And I think anyone that's been to the hospital lately and you think you're going to get 1 bill and you go home and you get 9, because it's a very fragmented system, and there's, you know, a bunch of independent contractors working in a building that you thought is a unified entity, I think is a surprise to most people.
Yeah, it's a great one. Question 4, would you rather have super strength, super speed, or the ability to read people's minds?
Absolutely the ability to read people's minds.
Interesting.
Wait, Devin, what if you couldn't turn it off?
I've got enough issues with not being able to turn it off.
Like you could hear them, you could hear people talking their heads all day long. I think it would drive me crazy. But for you, like what would be the use cases that you take advantage of the most on reading people's minds?
What are the use cases?
Yeah, like are there certain people you're like, gosh, I just wish I could know what the heck they meant, or
No, I think both personally and professionally, I think emotional intelligence is kind of an valued gift becoming more valued. But I think a lot of that is just understanding people and relating to people, both in conversation and interaction, and being able to read their minds kind of facilitates that. And I think takes away some of the anxiety of not knowing what others are thinking, how they're responding. So it may even be more relaxing for me if I could do that.
Yeah, definitely. Last question that we have, this one's COVID-19 related. So what is one hobby or activity you've gotten into since the beginning of the pandemic?
Yeah, that's easy. I've become a Peloton junkie during that. I got a Peloton during it, and I love it. And it's my, it's definitely a regular hobby that I hope continues post-COVID now. So that's
excellent.
Great. We'll make sure to add Peloton on this podcast. Maybe get your sponsorship, exactly. Devin. We'll work on that.
Yeah.
Exactly. That's the end of the Fast Five that we have for you, Devin. But I do want to thank you for being on the show today. You've definitely given us a lot of insights into patient engagement, patient education, and your career and your thought process in general. I know that our listeners will definitely benefit from the insights.
Yeah, and Devin, again,
I appreciate it.
Yeah, Devin, thank you so much. I know even our whole team here at Seamless, I'm sure a lot of our partners will be thrilled to learn more about your story and your thoughts. So thank you again, and looking forward to chatting with you again sometime in the future.
Great. Thank you very much.